day and welcome to this session. I will be discussing disorders of sexual development, previously known as intersex. I am Ajiboye Akinyosoye. I'm a gynecologist and obstetrician with Obafemi Awolowo University Teaching Hospital Complex, Ile-Ife. So our learning objectives for today is to understand where we're coming from about intersex and or disorders of sexual differentiation. I will be using this term interchangeably as we progress. We want to touch on the embryogenesis of these conditions. We want to classify and know the changes that occurred in terminology. We also expect at the end of this session that you know the etiology of intersex and then the clinical approach in management, and then want you to also know the various treatment options that are available. Then we also want you to know the controversies and the contemporary issues that have arisen on this topic of disorders of sexual differentiation. So we proceed to say that it was previously called intersex until a few years ago. And it is defined by the World Health Organization as a congenital anomaly of the reproductive and sexual system, which is seen in infants who are born with ambiguous or abnormal genitalia, or may also have indeterminate phenotypic sexual appearance. So there are individuals who are born with sexual characteristics or sex characteristics, that's the genitalia, the gonads, or even the chromosomal pattern that do not fit into the binary male and female bodies. So the appearances vary as birth. Some could be obvious as birth, while some are not obvious until evaluation is done, and some are not obvious until puberty arises, which will now necessitate further evaluation and will now actually reveal that there's actually a disorder in that of the sexual differentiation. There's just a slide here that is showing she looks actually like a woman, but when she raises her clothes, you could see male genitalia underneath. So this is actually one of those categories of intersex. Okay, so it has come a very long way. Hermaphroditus was described in the Greek mythology, and that's actually where that picture is coming from, where you have somebody with male and female organs. She is actually there looking like a female to you with breasts, but then she actually has a penis or a scrotum and scrotum. The Hawaiian culture recognizes that it's actually the indeterminate gender. And then that terminology, through hermaphrodites, was introduced during the Victorian era to describe those who have both female and male organs. That's the ovotesticular disorders. So in 1917, the terminology intersexuality was used to replace the term hermaphrodites. And then in 2006, the term intersex was now replaced with disorders of sexual differentiation. The views and the opinions about intersex vary from region to region, from culture to culture. And in Africa, many tribes view it as taboo and an abnormal situation, and that has led to infanticides and the abandonment of some children who are born with these disorders. However, there are some tribes, such as the Pokot tribe, they recognize that there's an existence and there has been no abandonment or killing of such infants or children who are born with such conditions. The problems that arise from the concerns of this condition are multidimensional, and they include the need to assign a gender for rearing, the psychological distress or being viewed as abnormal if no specific gender was identified for rearing the child. There are human rights issues. There are bullying that occurs in schools and institutions for women who have who are considered to be intersex, or people who are considered to be intersex. And then the sexual needs of these people are also important, the reproductive needs. And then medical conditions may also accompany some of these disorders. So it's difficult to actually estimate the prevalence of DSDs. Permit me to use DSDs as an acronym for disorders of sexual differentiation. Okay, so it's difficult to estimate because of varying parameters that are used. Also, some people reporting of these cases is also difficult because of the complex socio-cultural nature of these conditions. Okay, but we must know as a certain fact that congenital adrenal hyperplasia is actually the leading cause of DSDs worldwide. And below, I tabulated some of the prevalence that has been found for many of these conditions. For congenital adrenal hyperplasia, we'll find that maybe it occurs in 1 in 10,000 births. Klinefelter syndrome, maybe 0.01 to 0.5% of in the population. Same with Turner syndrome, accounting for about 0.1% of the population. Mayer-Rokitansky-Costa-Hauser syndrome occurs in 1 in 4,500 female births. Hypospadias occurs in maybe 1,200 to 1 in 10,000. The disparity is much because of the various reports that have come out on it. Vaginal agenesis occurs in 1 in 5,000 female births. And then complete gonadal dysgenesis is very rare, occurs in 1 in 80,000 births. So the basic principles underlying the embryogenesis is this. Phenotypic sex, that's the appearance, physical appearance, is determined by the genetic sex. And this genetic sex is determined by fertilization. Chromosomal sex basically determines what type of gonad is going to appear. And the gonads will eventually determine what physical appearance we're going to see. So the type of gonad that is now present is, determines the differentiation or the regression, as the case may be, of either the Mullerian or the Wolffian duct system, which eventually determines the phenotypic sex. Okay, the normal female carries 46 XX chromosomes, and the normal male carries 46 XY chromosomes. There is a diagram there that tries to describe what happens in the male and in the female. So there's an indifferent gonad, which, without the influence of the sex-determining region, I'll mention that later. If the sex-determining region on the chromosome Y is absent, there's the normal differentiation will occur to become a female. But in the presence of the testis-determining factor, then it differentiates to become a male gonad. So this is how it works. At 5 weeks, the gonads are bipotential. That means they can go in either the male direction or the female direction. And the germ cells, having migrated from the yolk sacs, they migrate into that indifferent or bipotential gonad. So the presence of that testis determining factor on the short arm of chromosome Y determines if that gonad will develop into testis or develop into the ovary. So we can see here that the SYR gene on chromosome Y makes that indifferent gonad to develop into the testis. And the Mullerian inhibiting substance suppresses the paramesonephric duct in the males and allows the mesonephric duct to differentiate into the internal gonads. And under the influence of testosterone and under the influence of dihydrotestosterone, the external genitalia is formed to appear like that of the male. Whereas in the female, because of the absence of the sex-determining region gene on chromosome Y, the absence of chromosome Y, the indifferent gonad develops into the ovary, and under the influence of estrogen, the paramesonephric ducts grows to form the internal genitalia of the female, and the external genitalia differentiates to become the female type. So the important hormones here are the testosterone and anti-Mullerian hormones, which are secreted by the Leydig cell and the Sertoli cells in males, allows the Wolffian duct to develop into the epididymis, the vas deferens, the seminal vesicles, and the Mullerian duct is regresses. While in the absence of the fetal testicular tissue and related hormones, the Mullerian duct, that's the precursor of the female genitalia, develops into the uterine tubes, the uterus, and the upper vagina, while the Wolffian duct regresses in the females. Okay, so this is a picture also describing what I have said earlier. So the external genitalia, like I said, now develop into the male external genitalia under the influence of dihydrotestosterone in the male with the aid of the enzyme 5,5,5 reductase. All these things are important because the absence of any of this would affect the development. So this is also a schema to show what happens in the males. In the absence of androgenic hormones, the genital tubercle differentiates to form the clitoris, the labia majora and minora, the urethral folds, and the lower vagina. Previously, the DSD classifications were called various names, such as male hermaphroditism, female pseudohermaphroditism, androgen insensitivity syndrome, and the likes. But now there's a new classification, and it suggests that female pseudohermaphrodites should be referred to as 46XX disorders of sexual differentiation, while the male pseudohermaphrodites are called the 46XY DSDs. The true hermaphrodites are referred to as the ovotesticular disorders. So those people referred to as XX males are actually 46XX testicular DSDs, and XY reversal that was probably called XY sex reversal is 46XY complete gonadal dysgenesis. So the classification under 46XY DSDs, we have the disorders of testicular development, that is complete or partial gonadal dysgenesis. That's they have the Y chromosome and they have abnormal testicular development. Okay. There could also be disorders of androgen synthesis, that's complete or partial androgen insensitivity syndrome, disorders of anti-Mullerian hormone receptor or androgen biosynthesis defect. Then you could also have severe hypospadias or cloacal extrophies under 46XY DSDs. So under 46XX DSDs, you have the important ones such as the congenital adrenal hyperplasia, you have vaginal atresia, you have there could be ovotesticular disorders and gonadal dysgenesis. So the classifications of sex chromosome DSDs, you have the 45X, that's the Turner syndrome and its variants. You have 47XXY, that's the Klinefelter syndrome and its variants. 45X or 46XY, mixed gonadal dysgenesis. 46XX or 46XY is chimeric ovotesticular DSDs. Okay, so the commonest cause of DSDs are the congenital adrenal hyperplasia, which is an autosomal recessive disease that results in deficiency of cortisol production. The common enzyme deficiency found in this is the 21-hydroxylase enzyme, and it occurs in 90% of cases. The summary is that there is inadequate cortisol production, leading to inadequate adrenocorticotropic hormone regulation via the negative feedback loop. And consequently, there are higher levels of ACTH in production, leading to adrenal hyperplasia. The diversion of the precursors of this, and then there is diversion of the precursors of cortisol production to adrenal androgen production. So you now have more androgen production in the circulation of such a fetus. Of course, the excess and adrenal androgens will lead to virilization, leading to, of course, now clitoral hypertrophy, and then the other features are associated with congenital adrenal hyperplasia. The other enzyme defects that are found include 11-hydroxylase deficiency and 3-beta-hydroxysteroid dehydrogenase deficiency. 3-beta-hydroxysteroid dehydrogenase can cause ambiguity in the 46XY fetuses. So other causes of excess androgen in circulation can include maternal androgen steroids. For example, if the woman is using exogenous steroids, or there are androgen producing tumors in the mother, there could be excess androgen production that could now cause virilization in the fetus. This category that we have described are formerly referred to as the female pseudohermaphrodites. That is, those who have been affected by exposure to drugs and hormones and also congenital adrenal hyperplasia. They were previously referred to as the female pseudohermaphrodites. Another cause of DSD is the Mayer-Rokitansky-Costa-Hauser syndrome. These women have normal female chromosomes, that's 46XX. However, and they grow up typically looking like women, but and they are both genetically and phenotypically appearing as women. However, they will present sometime in puberty or later with primary amenorrhea, and the problem that arises from the aplasia or agenesis of the Mullerian duct. That means that this is a picture of it actually showing the absence of uterus and uterine tubes, but they will have the ovaries present, and that's a picture in the 5 o'clock portion of the screen showing a follicle on the ovary there. So it's a problem of the aplasia and the agenesis of the Mullerian duct, and they end up with maybe blind ending vagina, absence of the cervix, absence of the uterus. They are not typically able to conceive on their own, but their ovaries can be, oocyte collection can be done on their ovaries, and then they have assisted conception in order to be able to have their own children. That is by the way. The other causes of DSDs include end organ resistance, and in this case, you have what you call the insensitivity of the gonads to androgens. Usually an X-linked disease, and it affects individuals who are 46XY. Here you have there can be total or partial resistance to androgens, leading to phenotypic appearance of a female. These people who appear to be women do not have a uterus, and they possess what you now have an undescended testis. They are usually infertile because they are supposed to be males, but they now appear as females. So the appearance ranges from very feminine to and they become increasingly masculine. For example, the Loeb syndrome appears very feminine to the more masculine one, so that the Riefenstein syndrome. And in them, you have high luteinizing hormone levels. This picture shows these women. They are actually looking like women, but they are actually 46XY. They will not have a uterus in them. They will have undescended testes. So there are many like that would actually appear like this picture was copied from the internet. Okay, it's in the complete androgen insensitivity syndrome, you have testicular feminization syndrome, and there is an inability to respond to the dihydrotestosterone. Okay, and it can actually be receptor positive or negative, and it presents in infancy with shallow blind ending vagina or primary amenorrhea later in life. The undescended testis needs to be removed because there's a risk of malignant transformation. such as gonadoblastomas that can develop. So we can see what we are talking about. In the absence of the male hormones or defective receptor response, the development of the gonads typically appear, the development of the embryo will go along the line of a female. So they will appear like a female because the androgen is either not, androgen hormones are not there, or the receptors are not responsive. In this case, we have an enzymatic defect, and that's a 5-alpha reductase deficiency. It affects 46XY, that's chromosomal males, but they are born with minimally virilized external genitalia at birth. In other words, the genitals will appear, they are minimally virilized, they don't look like males. But as they grow older and enter puberty, the penile enlargement occurs and more masculine features develop. Also, the realization that occurs as a result of direct action of the testosterone without input from dihydrotestosterone. We also have the Mullerian inhibiting substance deficiency, which now leads to the persistence of Mullerian duct derivatives. So in such cases, they are phenotypically male, but they have inguinal hernia. They have one inguinal hernia and an impalpable contralateral gonad. In that hernia sac, you may have remnants of Mullerian ducts, such as the uterus and the tubes in that hernia that has formed in them. There's the results from deficient. There's also deficient testosterone production and Leydig cell agenesis and hypoplasia. These two conditions, of course, in the absence of testosterone and production and Leydig cells, the male hormones that are supposed to lead to the proper formation of the gonads in 46XY is absent. The other causes of DSDs include the ovotesticular disorders, where both the male and the ovary and the testicular tissue are present in that gonad. Sometimes you have parts of the gonads being the testes and parts of that same gonad being the ovary. They were the ones previously referred as true hermaphrodites, and the chromosomal sex is actually 46XX. So the other ones you can have are the partial gonadal agenesis, where there is a chromosomal abnormality. The anomaly there is 46XY or a mosaic of 46X. Okay, one gonad is normal, and then there's an abnormal gonad present. And however, if there are ovaries present, the ovaries are properly well sited. Of course, there's an ambiguous genitalia, and there's risk of gonadoblastoma because of the undescended testes. In these cases, the gender assignment is controversial because they will appear already like there's a tendency to appear tilt towards the more female gender. Okay, so pure gonadal dysgenesis is another one where there's total absence of gonadal tissue, and then they appear phenotypically as males, though the genetic chromosomes could either be 46XX or 46XY, and then of course now have the 46X, that's Turner syndrome, is the most common in this category with pure gonadal agenesis. The clinical presentation actually depends on the DSD or the intersex, as the case may be, involved. As with many diseases and disorders, a good history is important. The physical evaluation and investigations that are required must be offered before any treatment is done. Common features that allow the doctor to ambiguous genitalia are the clitoromegaly or micropenis, the partial labial fusion, hypospadias or inguinal mass, and then the delay or absence of puberty. So you can see in this picture here, there is an enlarged clitoris there that looks like a micropenis, but it's an actually enlarged clitoris. And then the other picture, there's fusion of the labia there. And then in ambiguous genitalia arising from virilization of the XX female as a result of congenital adrenal hyperplasia, what you see is that you must look for history of genital ambiguity in the other siblings. You must also rule out issue of neonatal deaths because of the salt wasting nephropathy that occurs in the classic CAH, congenital adrenal hyperplasia. And then you must also rule out maternal steroid use. Okay, in the physical examination, you must pay a particular emphasis to the genitalia. Depending on which one, you can actually use the Quigley scale or the Prader scale to categorize and grade the extent of the ambiguous genitalia. The position of the urethral meatus should also be noted, and then the labioscrotal folds must be inspected, and then the degree and size of phallic enlargement should be noted. Okay, then you must palpate to identify the location of the gonads, whether they are in the scrotum, in the inguinal region, or in the abdomen. And then rectal examination can be done to feel for the cervix or the uterus. The Quigley scale is actually a descriptive visual system that grades genitalia between fully masculinized and fully feminized. And it's grade 1 to 7. Essentially, it's used for grading case of androgen insensitivity syndrome. Grade 1 is fully masculinized, which is can be referred to as mild androgen insensitivity syndrome, and while grade 6 to 7 are the fully feminized, which refers to complete androgen insensitivity syndrome. The Prader scale is similar to the Quigley scale and is used for grading ambiguous genitalia relating to congenital adrenal hyperplasia. And it's stage 0 to 6. Stage 0 is normal female external genitalia. Stage 5 actually is complete virilization with empty scrotal sac. There's female internal organs and is assumed to erroneously have undescended testes until the development of the salt wasting nephropathy, which is seen usually within a week. And that's actually what gives out the diagnosis in this case. While in stage C is normal male internal and external genitalia for Prader scale. Of course, investigations that can be done include chromosomal analysis, endocrine analysis. You also want to do electrolytes, urea and creatinine in cases of maybe congenital adrenal hyperplasia where there could be salt losing nephropathy. The androgen receptor could also be assayed. The levels of the 5-alpha reductase needs to be assayed, and anti-Mullerian hormone inhibiting substance should also be assayed for in order to make complete diagnosis. Imaging studies are important. Contrast studies outlining the genitalia is important. The CT scan and also ultrasound scan are also very important. Endoscopic studies such as assisted ureteroscopy and laparoscopy are also important both in the evaluation and treatment of these conditions. And of course, tissues that have been biopsied need histologic analysis for further management of the person, the baby or person involved. The management and treatment is multidisciplinary. The gynecologist, the pediatrician, the endocrinologist, the clinical psychologist, the urologist, genetics counselor, and social workers, among others. The timing of intervention is important. Medical intervention should not be delayed, especially those in association with classic congenital adrenal hyperplasia, because supplemental hormone therapy may be needed to be given also in such case. What are the goals of surgery? It's important to improve the potential for fertility. It's also important to have an outlet for menstruation in order to, and also to prevent or reduce urinary tract infection that can occur. Then they reduce the risk of cancer formations such as the gonadoblastomas in those who have high risk for it, and then those with exposed genitalia, such as the hypospadias, you need to close that, and then to improve urinary or fecal incontinence. The goals of psychological management are to alleviate parental distress over the atypical genitalia because it's a source of anxiety for the parents. Also, to make the appearance make it more normal for the person's sex of rearing, to reduce the effect of atypical genitalia on psychosexual development and gender identity, and improve the potential for adult sexual relationships. It's important to note that before I leave that point, because some decisions may be taken by the doctor or the parents on behalf of the child, depending on the DSD involved, while some need to be delayed and allow the person involved to be matured enough to take such decisions themselves. Several considerations are important while management is being planned, such as the phenotype, the functional potential of that external and internal genitalia, the fertility potentials, and of course the gender issues that can arise. The surgical management options that are there include the vaginoplasty, labioplasty, clitoroplasty, the repair of hypospadias, herniotomies, gonadectomies. In some cases, hysterectomies will have to be done, and then gender reassignment surgeries need to be done. The controversial issues and contemporary issues arising from this topic include issues such as the medical interventions versus intersex genital mutilations. The meaning of this is that some of these people, when they grow up, they believe that their genitalia should have been how it was when they were born, that any surgery that must have been done on them is actually genital mutilation. For example, in somebody with clitoromegaly who had the clitoroplasty done, could believe that it was actually mutilation of that particular gender. Then the gender assigned, another controversial issue, the assigned sex versus the gender identity in adulthood. Some people have been assigned, for example, a female gender at birth, but internally the person feels, because gender is a thing of the mind, the person feels that I should be a man. Why am I in a woman's body? So this could also is another contemporary issue that has arisen from this from the management of these conditions. There's also the issue of the early versus the late surgical repair, because some people believe that repair should be done as early as possible because healing is better, while some people believe that and the tissue is more elastic and supple, while others believe that repair should be delayed to allow for the organs to be bigger and to allow for more tissue for repair. The parental consent versus medicalized informed consent. The issue here is that many parents may not be knowledgeable about what the condition their child has, and they only rely on the information given by the medical experts. And of course, the information given by the medical experts is almost always medicalized. So they tend to be in a situation where they cannot actually make proper decision and give consent. They only have to rely on what the doctor gives them, the information the doctor gives them. Other issues that arise are the sensation and function following surgery. In someone with blind-ending vagina, you may want to wonder what sexual function she can have even after surgery, after enlarging doing vaginoplasty. How much of sexual function can she derive? So it's also an issue to consider. The medical photography have been considered humiliating. Many of our medical textbooks have pictures of people with ambiguous genitalia. Many of these pictures have been taken without their consent or without the consent of the parents, and they're being used for publications in in books. So this has been considered humiliating for those who have been involved, especially when they grow up and now find themselves in medical textbooks. By the way, the picture I used of the group of women is actually it was actually a picture of the women who have come out, because they have groups and organizations that further their cause in the maybe that talk about the problems they encounter. So they have associations and groups, and these people have come together to actually say, yes, we are a people with androgen sensitivity syndrome, and we are okay with the world knowing, and therefore they appeared in that picture. All right, human rights issues have also arisen from this, because the world is patterned after the binary sex, the male and the female sex. Those in between are not typically catered for by most organizations. So human rights issues arise from that. There's bullying, violence, and discrimination that can arise. Even in the world of sports, we have people who are considered to be who identified with the female sex, but they're actually intersex, and they have difficulty in proving to the world that actually this is who I am. So these issues occur time and again. And then Klinefelter syndrome, Turner syndrome are now issues being reconsidered. Are they actually intersex conditions or hypogonadic states? Because it's when you see somebody with a Turner syndrome, you typically think the person is a female. They have 46 X chromosomes. And so you now want to wonder, is it an hypogonadic state, or as in cases of intersex? So these are the controversies and the contemporary issues that have come out of the issues of intersex. So we conclude by saying intersex, or disorders of sexual differentiation, are groups of complex sexual differentiation disorders. Advances have been made over the years in the identification, diagnosis, and classification. Increasing awareness is being seen in aspects of psychological well-being and human rights of affected individuals. Physicians should equally improve on their sensitivities to such contemporary issues. These are my references. Thank you for listening.